Dr. Buse?
Thank you. So this afternoon, my role is to take a little bit deeper dive in diabetes and also discuss the drug therapies in diabetes and obesity. So diabetes complications are preventable today. There's a large spectrum of complications. The ones that we think of as being relatively diabetes specific are so-called microvascular complications, includes eye, kidney, and nerve disease. And we have wonderful data from Scandinavia, Sweden in particular, where they have a very integrated and focused healthcare system. There they've been caring for insulin-treated patients with diabetes in a systematic way for over 25 years and have demonstrated a dramatic reduction in the risk of complications, and also specifically that keeping the A1C as an index of average glycemic control less than 7.6% over an average of 25 years essentially eliminates microvascular complication-related disability. With regards to macrovascular complications, heart attack, stroke, peripheral vascular disease, which have historically been thought of as causing about 80% of the mortality in diabetes, we've had a dramatic reduction in the event rates for acute myocardial infarction and other macrovascular disorders. So over the period of time from 1990 to 2010, an almost 70% reduction in these rates. Nevertheless, there is still a much higher rate of macrovascular complications in the diabetic population as compared to those without diabetes. As a result of the reduction in these microvascular and macrovascular complications, I think we're seeing these emerging complications that Dr. Khan mentioned earlier, including cancer, liver disease, disabling arthritis, a variety of dementing illnesses, and heart failure. And one of the scariest things, which I won't touch on, other than to say, is that the impact of diabetes in young people who are developing the disease is as yet unclear, but certainly very frightening. So what would it take to accomplish the eradication of early disability and death from the classical complications of diabetes at a population level? I think the most hopeful piece of data that we have relates to the possibility of detecting early glycemic abnormalities and intervening, as was seen in the diabetes prevention program, but also early intervention in the setting of type 2 diabetes to enhance glycemic control. There is a legacy effect in that setting with dramatic reductions in the risk of complications over time. The treatment that must be administered is multifactorial, so lifestyle, education, and an assortment of medications targeting not only blood glucose, but blood pressure, cholesterol, and other risks in diabetes. And to accomplish this, we need to really develop individualized care delivered in a patient-centered way. This takes a great deal of humility for physicians and other providers that work together in teams, and we need a lot of societal and social support for patients to be successful in the long haul in this regard. What's missing most in the United States now is actually access to care. It is remarkable that in some parts of the country with poor access to care, amputations and blindness are everyday occurrences, and in most of the settings that largely care for people with good access to care, it's almost unheard of. Every day, still 1,000 patients die prematurely or are disabled as a result of diabetes in the US alone. And the barriers to achieving the goal that I mentioned a moment ago, beyond access to care, are addressing other poorly understood drivers of poor health outcomes. We have a total lack of systems of care with a few notable exceptions, and this results in a huge problem of non-adherence on the part of patients who are inadequately supported in the process, and non-adherence on the part of providers who are poorly able to deal with the complex therapies that are required to manage diabetes, blood pressure, cholesterol, and manage all the screenings and interventions that are required to ensure good outcomes. The focus of payers, unfortunately, is on short-term costs as opposed to long-term benefits, and that is an ongoing problem. There is total insanity in the marketplace where the poorest patients have to pay full price, and the middle class gets discounted rates through their insurers, who get discounted rates themselves. And there are clearly strange regulatory imbalances with regards to the way that drugs and devices and diagnostics and payers are regulated. So we have FDA mandates that we conduct cardiovascular outcome trials in the setting of diabetes, and when we demonstrate cardiovascular benefits, we don't have any regulation of payers that those drugs need to be covered by insurance plans. We have a system where you can get a device which improves obesity, approved with 200 patients exposed to the device for 6 months or a year, knowing that 3 or 5% are going to suffer pretty major complications. And in the drug area, you need to study 2 or 3 or 4,000 people over more than a year, and with a certain proportion for up to 2 years, with absolutely no tolerance for any adverse consequences in that population. And all of what I've described as being barriers to care in diabetes are just magnified in obesity, because if it's more recent emergence as being recognized as a real disease, as a condition that warrants intervention in our society. So we have a 70-year history of antihypertensive therapeutics, and since the 1980s, it's been known that blood pressure management reduces complications and prevents death in patients with diabetes. Hypertension management is well instilled in our healthcare system. The diabetes story has been a more recent one, though we have insulin since 1921. It's really been in the last 2 decades that we've had an explosion in the development of drugs for the treatment of diabetes, and it's only 2 of these classes of drugs that have had clear-cut demonstration that administering these drugs in high-risk patients are associated with reductions in death and disability. With regards to weight loss, it's almost laughable. We had essentially no drugs until 1997, and arguably now have 5 classes of drugs approved for managing diabetes in the United States today. There are exactly 0 drugs in phase 3 development currently. And this is a list of the drugs that are approved for the management of obesity. The first one is not approved for chronic management, and what you can see is the amount of weight loss that's seen on average is pretty modest, from 3 to 10% on the list. Many patients are looking for more weight loss than that. Unfortunately, most of these drugs are actually not covered by insurance plans, and so patients are required to pay cash for these therapies in many cases. And as you can see, the potential side effects are quite broad, and often scare off the primary care doctors that really would need to manage these kinds of therapies for us to have an effective program of tackling obesity based on drug therapies. So thank you very much for your attention, and I'll turn it over to Dr. Batterham.